Okay, welcome to our live stream at Duke Spine Institute. Our patient is having the Duke laser disc repair done at L5-S1. Little numbing medicine, lay still. You're doing great.
Keep your arm still. You gotta keep your arm really still. Alright, we're all done with that. Okay, bring your arm up for me.
And he has a herniated disc at L5-S1 with both sides narrowing. Shot. All right. Let's get some numbing medicine, please. You're doing great. Lay still. I'm going to give you some more numbing medicine. That's just numbing medicine. Anything we can do to help him, Dr. B? Shot. Let's get those cables out of the way. Everything's okay. Shot. All right. So first thing we're going to do is get into 5-1 on both sides. Shot. 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 AP. Shot. Quick shot. Mm-hmm. Shot. All right. May have to start a little bit lower. Shot. Shot. Can we make that 5-1 a little bit better? We're off on orbit, we're off on WAG. Shot. That's better. I think he moved a little bit. That's better on the orbit, right? What about the WAG? Shot. Can you see the pedicles? They look pretty good. That looks good to me. Shot. It's just I'm not able to get south enough. Hitting bone. Yeah, it keeps hitting bone. It's very strange. Gonna have to start more lateral. Shot. Wow. Shot. Very unusual to have this much trouble getting into 5-1. AP. He's got some kind of abnormal vertebrae there. You can see it on the x-ray. Somehow it's moved again. See if we can line it up better. That's better. Very unusual. Shot. Keep hitting bone. Shot. 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 That's the best we've gotten so far. Say, no, hold on. Shot. Okay, AP. That's the best we've been so far. Gotta say, this is very unusual. You can see his pedicle. Show the pedicle 5. Well, next time. It's too late now. Shot. That feels like the herniation right there. That was probably the hardest I've ever done. Num. That's incredible. This is very unusual spinal anatomy. It's probably contributed to his problem. So I normally don't start this far lateral, and I don't angle that steep medial and inferior. And it's very unusual. And if you look at his x-ray, you can see just how unusual it really is. Shot. I'll show you guys on the next view when we get a shot here. Shot. We need to be on an AP view to really understand just how unusual it really is. Shot. 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 AP. It's too high. You never know how difficult it's going to be to get into somebody's oh yeah, show them the pedicle of 5. So show them the pedicle of 4. Go up. That's the pedicle of 4. It's perfect. Go to the left side, the other side. Perfect. The one above. Perfect. Perfect. And then look at 5. Weird. And then look at the other side. Really weird. Okay? Totally abnormal. So he's got what we call a segmentation abnormality. Go ahead. Go back to a lateral. When his spine was being formed in utero, it didn't form properly. And shot. Anyway, what I'm getting at is that's not the issue right now. The issue is getting into the disc. And that's what I'm struggling with. Shot. And it has nothing to do with the segmentation anomaly. I mean, it does and doesn't. The fact that he has a segmentation anomaly, lots of people do. But having trouble getting in is not normal. Like, I have lots of people with segmentation anomalies from birth, AP, but I get in all the time. It's no problem. His, for some reason, is making it very challenging to get in. I think his spine is anterior too. I need to be more medial. Let's see. Yeah, go back to I may be too lateral, which is okay. I just need to be a little bit more medial. Shot. 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 All right, let's go with an AP. So I'm using a combination of front, back, and side-to-side views to try to navigate this needle into exactly the spot. And it's extremely challenging, but that looks really good right there. Back to a lateral. You can see the S1 pedicle, the L5 pedicle. I'm almost at the mid-pedicular line. So it's actually really nice positioning. Shot. Perfect. Got lucky. Very lucky. All right, now we need to go up north. And let's get a shot. It's too far north. Down south, shot. All right, so that's 5, right? 4, 3, 2. 2 is there. Yeah, I agree. So bear with me. Shot. 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 Should be right on the shot, the set. So we know that, let's go south just for a second. Shot. That's 5. Now move up. Shot. 4. Move up. Shot. 3, 2, 1. We're at 1, right?
Yes, sir.
Move up a little more north. Slowly. Shot. Okay, that's still 1. Right? Everyone agrees I'm at 1.
Yes, sir.
Can feel it. All right, now go more north. All right, so that's 1 down there. 12, 11, 10, 9. So just stay where you are for a second there. So there's 1, 12, 11, 10. Yeah, open that up. Close the front down a little bit, just a little bit. So it's 1, 12, 11, 10. We're doing 10, 11, and 9, 10, correct?
Yes, sir.
Just stay where you are for a second. Shot. So I'm a little bit too high. Shot. Um, 1, 12, 11. Let's get an AP. I think I'm too medial, which is fine, because I expect to be. 1, 12, 11, 10. If I can get in, yeah, I'm too medial. And there's 12, so I'm at 1, right?
Yes.
You agree I'm at 1, you can see it there. That's 12, 11, 10, 9. So basically, 1 is reliably without a rib. Everyone agrees?
Yes, sir. Yes, sir.
All right, so we don't need that. So I just need to go more lateral, and we're good. Let's go back to a lateral view, please. 12, 11, 10. All right. Shot. 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 So we need to clean this up just a little bit. Maybe some orbit. Try some orbit. I think we're okay on WAG. Maybe the other way on orbit. Just a little bit. Let's see what happens. I think that's better, right?
Go a little bit more.
Huh?
I'm going to go a little bit more, see if that's...
I don't know. Is that okay? It's a little too much. Go back a little bit. Alright. We're definitely caught up on the facet. So I need to go. Just give me an AP and let's see what we're caught up on. So you're watching and getting Yeah, I'm too medial. You're watching, folks, and you're getting the surgeon's thoughts as I navigate. So you're getting to hear everything I'm thinking about and analyzing from an experienced endoscopic spine surgeon. Okay, I could probably be a little bit more lateral. So just you can. Oh, it's really fascinating on that view right there. You guys see the view there? It's really cool.
Ray of sunshine.
No, look at the front. See, this is the telltale sign. I've seen it before. Look at the front of 10, 11, and 9, 10. Look at the bone spur there. All the other discs don't have that. That, yes, that tells you these are damaged discs. We struggled so hard to find them. All right, lateral. Shot. Shot. Give me an AP. Huh? Yeah, but the key is it shows there's an injury.
You said 30 years ago.
Yeah. So it's an old injury. You can tell by the spurring. All right, so I'm still just a little bit too medial. 12, 11, 10. Everyone agree that's 10, 11, correct? That's one of the two discs we're doing. Just need to get around this thing. They were so close. Shot. There we go. Shot. Shot. So we're very close. Shot. All right, I need an AP. We're just coming around the facet joint. That looks good. Perfect. It'd be nice if we can shoot down the disc, but that's fine. All right. 12, 11, 10. How's he doing? Everything good? Shot? Shot? Right at the bottom there, you see that? Mm-hmm. I'm on the disc, but I'm at the bottom of the end plate on the disc. Shot? I've got to just see we're going into the disc right now. It's perfect. Doesn't get better than that. All right, let's just all verify we're at the right place, okay? Because if I know for sure I'm at 10, 11, which I believe I am, let's count from south up. Let's just try, okay? Shot. A little bit. I mean, that's got to be 5 right there. Shot. So now go north a little bit. Right there, shot. All right, a little more north. So it's 5, 4. I see 4. Shot. 3, 2. Hold on. 1. Go north. Shot. Keep going north. I see 1. Shot. 12, 11. Keep going. Shot. Yeah. So for me, on the lateral views, we're at 10, 11. Let's go AP one more time. We're going to need him awake in about 5 minutes. Perfect. All right. Let's get the next one in. All right. All right, so we got to get this next one in. You can see the lung fields right there. And Jordan is doing his very best. I think this is going to be one of the more painful of the two. So, huh?
There's a sharp lateral space there, diaphragm.
Shot. Shot. That looks pretty good, right, Luis? It's lined up nicely. Shot. There's bone. Shot. Right on the facet. Shot. I feel like I'm too medial. But let's get an AP. Just to verify. So this is a very challenging case, folks, for many reasons. Every single disc that I've been accessing, I'm too medial. So I'm going to pull back and go a little bit more lateral. I'm already touching the facet, and I want to be just skiving past it. So I'm erring on the side of caution, being a little bit more medial. Shot.
Are we doing 4 discograms?
We are. No, 3. Shot. Any way you can line up that 9-10 better for me? I think that's worse, Jordan. It wasn't an orbital issue. It was more of a wag issue. Uh-huh. All right. Just so close. Can feel the facet. Shot. Shot. So close to getting around it. Shot. Shot. So close. Shot. I can feel the arthritis in the facets as I'm trying to get around them. I'm a millimeter off. Shot. That might be it. Shot. Literally just dealing with not even a full millimeter. Give me an AP. Dealing with like literally a 0.5 millimeter movements in direction around the bones. So it makes it so challenging. God, it looks perfect. Yeah. Looks good. Lung fields look good. I don't see any pneumothorax, so it's good. It's good. He's stable, right?
Yeah.
No, we're pretty much there, so I will need him awake. Shot?
I just turn everything off.
Yeah. All right. Shot? This is 9-10.
I wanted him a little more relaxed while you're doing this.
No, you did the right thing. We're in. So we're in 9-10. We're in 10-11. Let's verify that we're in the right levels. One more shot. Let's get an AP. I don't know, Luis.
Yeah.
Just
How you
thinking.
doing, my friend? You okay? How you doing?
Debating lumbar cervical scope up
Oh,
there.
okay.
I mean, those are big discs, you know? Have it ready. All right. Let me know when he's ready. Yeah, you can go to a lateral. You can go to a lateral view. All right, so we're going to let our patient wake up, and then we're going to test his discs. So he's come from far away, and we know L5-S1 is a likely source of his pain because he has a double herniation, one on the left, one on the right with annular tears. L5-S1. And his pain was localized right there. Then he also has pain up here in the thoracic spine at T9-10 and T10-11. How do we know that? Well, we actually had him localize where his pain is. We put paper clips there and we did an x-ray, AP thoracic, and it showed the paper clips exactly at 9, 10, and 10, 11. When you look at his MRI, he has degenerative disc disease at 9, 10, 10, 11, which means the discs have been damaged, apparently 30 years ago. 30 years ago, right?
30.
He has a 30-year history of pain. No problem, just take your time. So we want to verify that these are the source of his pain. No worries. Oh, let me think, Luis. What do you think? I think we're okay. We could do either lumbar or cervical. I think we're in the middle.
We can try it.
We need a thoracic scope someday, right?
Yeah.
Can I have that chair? All right, any questions from the audience?
Yes, we have two questions. This first one comes from JMC on YouTube.
JMC, nice to meet you.
They ask, what are your thoughts on SI joint injection?
Oh, SI joint injections? Great question. So first of all, the SI joint is literally the third most common cause of back pain, following discs, which are about 90%, facet joints, which are around 8%, and then the SI joint. So third most common cause of back pain, sacroiliac joint. All right. Now, how do you treat it, or how do you diagnose it? You diagnose it on clinical exam. So you have the patient pull their pants down, you go to their back, and you press on the back of the SI joints, and they will have severe tenderness and pain. As long as they're currently having an episode, you'll be able to make the clinical diagnosis sacroiliac joint dysfunction. Then what we do is we are going to do an injection of the SI joint with Novocaine. And that Novocaine will numb up the joint. And if their pain goes away, then you made the right diagnosis. It's a sacroiliac joint. On the other hand, if the pain doesn't go away, you didn't make the right diagnosis. So injection of the SI joint will take away the pain temporarily. But if you want to get rid of the SI joint pain permanently, you need to do a rhizotomy. And the best rhizotomy in the world right now is the Duke plasma rhizotomy. How are we doing, guys? Luis, everything okay? Hey, Jordan, would you mind wheeling the fluoro up from the lumbar? Just show me the thoracic's lateral. All right. Just get a quick thoracic x-ray. I want to see how big those thoracic discs are. They're pretty good size. They're almost as big as a lumbar disc. So I think we're okay with a lumbar scope. Luis, I think we're okay with a lumbar scope because the thoracic discs are huge. All right, everyone. Great questions. Are you awake?
You okay? He said yes. Keep your head still, please.
Yeah, don't move, all right? Don't move. Are you having any pain? I need to hear his answer from you guys. Any pain?
Are you having any pain right now? Any pain in your back? No.
Any pain?
You can't shake your head. You got to say yes or no, sir.
All right. Look at him move. Look at him move. How bad is that on a scale of 1 to 10?
Give us a number. 1 to 10.
How high did it go?
7?
How high did it go? He's grinding his teeth. It's a 10. Did he say 10? You hear him? How high did it go?
Number.
11.
Said 11, all right.
Is that where you get back pain? All right, 11 over 10, concordant, 5-1.
Okay,
Okay.
head down for me.
And you,
Head down.
Jordan, show them the tear.
Still. Just
So he's got a double herniation at 5-1. He's got massive pain. We're not ready for this. Oh, no. All right. Is he awake still?
Yep.
Is that better? Lay still.
Don't move your head.
Don't move your head. Lay still. We're almost done. We're going to put you to sleep.
Keep your head
Good news. That bottom disc was the cause of your lower back pain. You comfy? Not yet.
still. More.
Not yet.
You can take off.
All right. We good? Are you comfy?
Yes. Keep your
Don't move your head. Just answer us verbally. What did he say? Can't breathe? He can breathe. He's obviously breathing. He's talking. How bad is that?
What's your pain score? Give us a number.
Shot. How bad is that on a scale of 1 to 10?
Give us a number.
How bad is that? Still a little
Can you give us
sleepy.
a number?
How high does it go? How high did it go?
How high did it go? What number? Is it a 10, 8, 9? 10.
10. Is that where you get your back pain typically?
Yes.
10 over 10 at T10, T10-11, concordant. All right, sorry about that. Is that better? All right, so great news. The disc that we thought was causing his pain, number 1011, is indeed causing his pain. Don't move. Lay still. Lay still. Lay down.
Don't move.
All right, is the pain gone? It's probably still bothering because there's pressure in that disc. You guys see that thing? All right. Well, we got one more to go. How bad is that on a scale of 1 to 10?
Give us a number. What number? 8.
All right. Is that where you get pain? All right, let's put him to sleep. 8 out of 10. Concordant. Let me put a little more. Yeah. I'm going to pull it back just a little bit. Yeah, I know. Is that where you get your pain typically? Can't even get any in. There's so much scar tissue in there. But he's definitely feeling it. Yeah, we're good. All right, where do you want to start, Luis? All right, you got those numbers? So 5-1 is 11 over 10 concordant. T10-11 is 10 over 10, and T9-10 is 8 over 10. All right, Henry, you're welcome to ask some questions. You can fire the laser. And let's get some pictures at 5-1 shot. Looking good.
Next question comes from Samir on YouTube.
Samir, yes, Samir, we'll take your question.
They asked, you are entering from the annulus, so will it not tear the annulus more?
The annulus is already torn, Samir. It's a big tear already. It's bigger than what we're doing. It will not tear more. We've never seen it tear more. We always see a giant tear, much bigger than the tube. Much bigger. It's a great question, but the reality, Samir, is that, man, he's got some thick skin. The reality is that the tear is already big, and we don't make it bigger. We just clean it. Shot? 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 I've never operated on a tear that's smaller than the tube. You can always see once you get the endoscope down there, you can actually see that the tear is bigger than the tube. Shot? That's where we are.
Yes, sir.
Great question, though. Let's keep going. Any other questions? Shot?
No current questions, but we do have a comment from Canes25 on YouTube saying, Canes is still here doing a Duke marathon today.
You and us both, Shot. We're doing a Duke marathon as well. I'm glad you're here, Canes. Yeah, it's been a long day for us, and everything, fortunately, has gone well for our patients so far. We had to add a patient on today who had some hardware from a posterior cervical fusion that was basically coming out of their, about to come out of their neck. So we had to add that on, and that really made our day a lot longer. So, but we got it done, and we're almost done for today. Good news is, I feel confident these discs are causing this patient's pain now that we've done the discogram shot, and I think he's going to do really well. Shot? All right. Go ahead. Let's get the scope out, and let's get this done. So we're doing a bilateral 5-1 because he has bilateral annular tears and herniation. The 5-1 is the most painful disc. It was an 11 out of 10 concordant, meaning it's his typical back pain he gets every day. So it's good news for him that we found the right one.
Yes, yes, please.
I will tell you.
1 second. Pray, turn on.
You have white bounce?
Good.
All right.
Thank you.
We had to white balance our camera. All right, there it is. There's the tear. And you can see the blue herniation. So already we're hitting the jackpot. Now this patient came from overseas as well. Huh? Well, it's overseas, isn't it? Puerto Rico? I don't know about you, but do we know anybody from Puerto Rico that works here? She's not the only one. All right, we have any questions from the audience?
No current questions, but we do have a comment from Jules on Facebook.
Jules, absolutely. Love to hear from Jules on Facebook.
They said, I have SI nerve pain. I had sciatica for 10 years, one bilateral discectomy. I'm still struggling with nerve pain.
We can fix your pain, Jules, at Duke Spine Institute. We have the technology to diagnose the source and to fix it, okay, with minimally invasive, just like you're seeing now. Just got to work on Patel's incisions. Right? Luis, you got to work on that with me, all right? Yeah. 1 incision, maybe 2, maximum 2. There's no reason why we can't get the SIDPR done with 2 incisions. All right. All of our patients have gone home, right? I saw them. Doctors. Oh my God. I can't believe you're saying that. Doctors don't go home. Well, you're not sleeping here? Thursday night. I don't think Thursday's as bad, is it? Huh? No, I think we had one that moved, right? What do we have Thursday? No, I think 4. See? 4 is a good number. 4 is a good number. But that's if all 4 go. All right, Henry. Let's show the audience, why do these discs cause so much pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
We did it. All right, welcome back. You can see how a herniated disc causes so much pain through inflammation within a tear in the back of the disc called the annular tear, specifically the posterior annular tear. That was discovered here at Duke Spine Institute. And for 16 years, we've been curing people's pain by repairing posterior annular tears. All right, you said you had a question or a comment?
Yeah, we have a question and a comment. This first question comes from Mary on YouTube, asking, when you say 5-1, you're meaning L5-S1, right?
Of course, that's what we mean, L5-S1. That is correct, Mary.
And then
there is no other 5-1.
And then the comment comes from Jules on Facebook saying, I had Cauda-Equina syndrome, so I left with complications. I was told I will have to live with this pain.
You had Cauda-Equina syndrome, and I don't know exactly what's wrong, but I can tell you if you're having pain, we can get rid of it. They don't know how to fix it for you. Your doctors are literally clueless, but we can figure it out and we will fix it and get rid of it. I don't think there's a single pain patient we haven't been able to cure at Duke Spine. It's all a matter of making the right diagnosis. That is the key. Diagnosis, diagnosis, diagnosis. I say it over and over and over again. MRIs don't tell you the diagnosis. Unless you have it. Even if MRIs never tell you the diagnosis, okay? No matter what it is. If it's an infection, it doesn't tell you what's causing the infection. Is it MRSA? Is it strep? Is it pneumococcus? I mean, what is it? And then if it's a tumor, it doesn't tell you what kind of tumor. Is it prostate cancer? Is it lung cancer? Nobody knows. So MRIs are limited in what they tell you. And doctors, for the most part, have no clue how to figure out what causes pain. So what they do is they just give you pills or shots or stimulators or things that really don't fix the pain because they don't know what's causing the pain. So they just guess. At Duke Spine, we don't guess. We determine the source of pain through careful examination, experience, testing, and once we know your pain source, we can fix it. No doubt about it. It's either going to be a disc pain, a facet pain, a sacroiliac joint pain, a piriformis muscle pain, a coccydynia. So there's a limited number of causes of pain, and we know them all. And there's not a single one that we can't fix except for iliac crest donor site pain. That's basically pain that comes from the place where they harvest your bone graft on your hip when you're doing spinal fusion. That's the only pain that I know of that we can't cure. Now there's also arachnoiditis, which causes leg burning, which we can't cure. Okay? But as far as sources of back pain, every single source of back pain has a cure today. It's just your doctors don't know it. That's the problem. And they probably won't know it in their lifetime, because unfortunately it's going to take time for everybody to learn all the causes. And we're trying to help with that, but there's only so much we can do. We're a tiny company. We're not a big clinic like the Mayo Clinic. We have one building, 20,000 square feet, with 70 employees, and we're a small company. So there are things that we can't do because we're so small. All right, Henry, what other questions do you have?
No current questions.
I like the term tiny but mighty. Right, Dr. Berndes? Dr. Berndes is sapped. Look at all the scar tissue here at 5-1. That is the herniation, by the way. L5-S1. It's very badly scarred up. Berndes, you know what you need? You need a martini. Do you have a jacuzzi at your house? Huh? You sit in it? I love the jacuzzi, man. Especially after a long day like this, you sit down and your muscles get, you feel the tension leave. There is one muscle that is super tense right now in my body. Anybody want to guess what it is? See how well you know me.
Let's say, your
What?
rhomboids.
I couldn't hear you. Rhomboids? Rhomboids. Good guess. That's not it. Hey, feet, really good. That's not it though. Henry? What? I have a muscle in my body right now that's super tense.
Okay.
Yes, like it's like spasming.
Oh, thigh?
No. No. Luis? Good guesses, all of you guys. You want to venture a guess, Luis?
Let's do
Latissimus dorsi. Actually, I've been unfair to you guys, but since we had lunch like 7 hours ago, it's my stomach. My stomach is tightening up. It wants food. I got you guys. Pretty good. All right, we're just about done. One more minute. This is 5-1, remember? And so far it's gone well. Let's see if we can see the nerve root. There's the nerve up there in the fat. You see the veins around it? Looks great. I'll try one more grab and we're done. And then we need to irrigate, move on. Yeah. There's nothing there. Good job.
Nice one, please. Thank you.
That went very well. Luis, should I switch sides with you then? Yeah, I think so, right? Come over there. All right. Little antiseptic. Little irrigation. Any more questions?
No current questions, but we do have a couple comments from Canes25 on YouTube.
Sure.
A couple first comments are saying, remember the song "King of Pain"? That should be your theme song because you
By the
are
police.
Yes.
By the police. King of Pain.
because you are the painkiller.
Yeah. Every little thing she does is magic. Where's the music? Thank you. Painkiller. That is not a bad name to have. I'm not addicting in any way. I'm not addicting. I'm not physiological addiction. No physiological, what do you call it? Tolerance. right? You don't build tolerance to me. Most people can't tolerate me. No tolerance. So no addiction to me, no tolerance to me. I'm the best painkiller there is. Yeah, let's listen to King of Pain. Yep. There's a little black spot on the sun today.
This is our music.
It's the same old thing as yesterday. There's a black cat caught in a high treetop. See, I know all the words, because I am the king of pain. And the wind won't stop. Shot. I have stood it before. Shot. Shot. So this is a really deep to be the king of pain. Great song, by the way. Did you guys know about the Police? Huh? I'm not talking about the Popo.
They were actually one of the first bands I got into when starting out drums.
They were my very first favorite band. Shot? Back in the, like, 82, 83.
Stuart Copeland, who is the drummer for the Police, in my opinion, is like one of the most underappreciated and one of the most respected drummers that you can ever listen to. Personal preference.
Let's just get a quick AP. I want to make sure, because that needle came back a little bit. It's a great album. It looks pretty damn good. That's my soul up there. Anybody know what movie Sting was in?
Dune.
Dune. That's it. My favorite. One of my favorite movies. He was great in Dune. You guys know what we're talking about?
I didn't like that.
You
Yeah,
didn't
with-
like the movie? What are you talking about?
That's with The Rock, right?
The Dune?
Doom?
No, that's not with Rock.
Oh. What am I thinking then?
No, that's an old movie. They just remade it. The remake was, I wouldn't go watch it personally. It's kind of an insult compared to the original Dune.
Did anyone see The Sound of Freedom?
I have not seen The Sound of Freedom. Is that
Highly
good?
recommend that.
What's that?
Oh,
Henry likes it.
Dune. Oh, somebody commented Dune, D-U-N-E.
Yeah.
The David Lynch version.
All right.
Yeah.
Yep.
I want to see the new Harrison Ford.
I saw the new Harrison Ford movie.
Was it good?
It was all right. There's some deep fakes going on in there.
A lot of
A lot
deepfakes.
of what?
A lot of deep fake. You know, I don't know if you hear, but all of Hollywood's up in arms because they're taking the likenesses of actors, paying them minimal money, and then they're capturing their likeness for use for many years to come. All deep fakes, all, AI generated stuff.
Thing with that is that some actors are not even being paid at all. It's just all studio consent.
Honestly, in the future, why even pay actors and actresses? Just have digital famous actors. Like somebody who doesn't even exist. You know what I mean?
Well, that is an argument right there.
Like you could create a persona, a digital persona that doesn't even exist and make them famous in movies.
True,
And then you owe nothing.
but where's the authenticity?
Right, I agree. I'm not happy about that, but, they can do that. Like right now we're taking people we're used to, like Harrison Ford, and digitalizing them and doing these deep fakes. But someday we won't even have a Harrison Ford. We'll just have, you know, Elijah Gooding, who nobody even knows about, but they make him famous or her famous because they put him in so many movies, right, as a hero.
I know what they're doing in specific is that they're trying to make a new Beatles song that was recorded but not finished, and then they're trying to implement John's voice into AI and
Wow.
making it full. Yeah.
So they're doing it for music too. Pretty soon they're going to have a Dr. Duke Majan. Fake surgeries you can watch. Contrived.
Canes25 commented, I'm pretty sure that that's what's happening and been happening. Look at CGI Joe Biden, that is.
All right. That was good. Everybody's laughing, but remember, we don't get political, all right?
Of course. Yes. And then we all just got a comment. Well, this is from a little bit before. This comes from Bird819 on YouTube.
Bird819 on YouTube. Welcome to our live stream. You guys see the tear, by the way? The blue thing is the tear. That's the herniation. The blue stuff is the herniation inside the white tear. The white tear is the annulus fibrosus. It's the wall of the disc that's been ripped open, and the blue stuff is now coming out through it, and that's why it's blue. We stain it with a blue dye because it makes it easier to see it. This is all scar tissue. This is all herniation, by the way. This whole mound right here. It's a mound of herniation and scar tissue. Look at the calcium, the gold color. Man, the scope is beautiful, Luis, by the way. All right, Bert, bring it on.
They commented, if I ever need back surgery, I want this guy to do it. He is pretty chill considering what he's doing. That is awesome.
Thank you. Yeah, we love what we do, to be honest. I mean, I keep telling my staff that. That's why they get to stay late, because we love what we do. I don't think it's going over so well, though. They're glaring at me. Honestly, my wife called me from New York. She said, oh, the food here is so good. You would have so much fun. And I'm like, I'm happy where I am. I don't really, I mean, how many times can you have good food, right, in your lifetime? How often do you get to fix somebody's pain? Right? This is priceless. I would much rather do this than...
We're stuck in Chick-fil-A heaven.
Yeah, I bought you guys, what did I buy you guys for lunch? Cleos? Celos? Celos? Look at all the red, guys. That is inflammation right there. Remember we talk about the inflammation? That is the inflammation. Henry, that's a really good inflammation shot right there. See the laser? That's 1 millimeter wide. And now I'm blasting away all the inflammation. That's, by doing this, the pain goes away. Back pain. Even the leg pain. Look at all that inflammation.
I moved here from Vegas. I had to suture up my taste buds. They were traumatized. I needed
What?
stitches.
What are you talking about?
Those are my taste buds when I moved from Vegas to Melbourne.
What are you talking about? The food is not good? Vegas food is good?
Compared to Vegas,
Oh, please.
it's got the best food.
Oh, Vegas doesn't have the best food.
It's got great food.
Thank you. Vegas does not have the best food.
I mean, New York is better, obviously, but
Yeah, New York is
one of the
probably
cities.
better.
Probably one of the better cities in the United States.
I think Orlando has great food. That's my opinion. I mean, it's not the best.
I like that restaurant, Cooper's Hawk. I think that's a good.
Cooper's Hawk?
I think it's very good. Winery is very.
Where is that one? On International Drive?
Yeah, I like that winery. Yeah, there's very good wine.
You know what just opened up here in Melbourne? Masa, about a year ago. Have you been there? Anybody? Masa, M-A-S-A.
What is that?
Mexican. Really good Mexican.
Really?
Really good Mexican. I'm dead serious. I could eat there every night.
Really?
It's down by, shoot, my wife drove the other day. I can't remember. Look at that tear right there. Look at that. Just about done. About 5 minutes left on this disc. It's down in like Palm Bay, not Palm Bay, Ugali. I mean, Masa, M-A-S-A, I think. It's like a brand new Mexican restaurant. It's really good. Oh, you know, yeah, it's on Ugali. It's kind of near Texas Roadhouse. All right, sorry. We're talking about food, but we're hungry.
Indian Harbor.
Indian Harbor. Huh? There. All right, questions? Anybody?
We just got a question from Kane25 on YouTube, and they asked, Doc, what's your favorite meal?
My favorite meal. Boy, you know, you're trying to make me feel worse by making me think about food. All right, let's see. Well, first of all, my favorite meal is one that my wife prepares. Is she listening?
I do not know.
I'm just kidding. No, my favorite meal is one that my wife prepares. You feel that, Luis? Temperature change? And it's probably mango habanero burritos. Mango habanero burritos. Okay, there's wild rice, you know, and then it's got chicken, and it's got mango habanero sauce that you dip it in. Oh, we're done. That's it. And the other one that I really like, since I'm on a roll here, is that my wife makes is stroganoff, beef stroganoff. Oh wait, I love beef Wellington too. Beef Wellington, right? You make beef Wellington? Dude, I'm gonna give you a day off just to make beef Wellington and bring it to me. Seriously, I'm gonna pass out too. Sorry, we're hungry here. Just about done. 2 more to go, thoracic. But thank you for bringing that up, I think. It's motivating me. But no, that disc went very well. We did both sides, and he needed it on both sides. You saw he had a lot of inflammation on the right, more even on the right than the left. Chicken eggplant parmesan? I don't like eggplant. I'm not crazy about eggplant, but I do like chicken parm. Shit, I love lasagna. Good lasagna. Huh? Your wife does? Hernandez, I'll give you some extra time off if you bring me some food. Okay? Shit. Oh, too funny. All right, but Orlando does have really good food. Orlando.
What's like your favorite, what's your favorite Mexican restaurant?
In Orlando? All right, the honest to God's truth is the Mexican in Orlando is not great. I wouldn't travel to Orlando for Mexican. I haven't found, huh? The Indian food is good. We live literally 5 minutes from Saffron, and the food is really good there. Really good. I like Indian food a lot. All right, so far we've... Yeah, my wife had Korean with Arias yesterday in New York. They said it was amazing. Okay, sorry, we're digressing on food. But we have now finished the 2 lumbars, and I'm getting ready to start my thoracic. Now, with thoracic, I can use one of 2 scopes. I can use the smaller scope or the bigger scope. And typically, I would use the smaller scope for a smaller disc. But when you've got a big disc, it's okay to use a bigger scope. And it's probably better for the patient to use the bigger scope. Whew, that's tight. Shot. Because his discs in the thoracic, especially the lower thoracic, like where they are, these are T9-10, 10-11, they're almost as big as the lumbar. So using a small scope will be really bad. You won't get the job done. So that's why I choose, let me have some num-num. That's why I choose the bigger scope for the thoracic for him. Now, if we were higher up, around 4, 5, 3, 4, 5, 6, maybe I wouldn't use the same scope. It's a little bit too much dye on there. There we go, I had it.
We have a question.
Shot? Okay, a question, no problem.
This comes from Spyros on Facebook.
Hello, Spyrus. Welcome to our stream.
They asked, does the patient feel it when you insert the tube? What is the blue dye you use, and does it dissolve over time?
Yeah, so does the patient feel when you insert the tube? The answer is no, they're not supposed to. But even if they did, because they're asleep, the patient's asleep, so they're not really feeling it. You just saw me, I put the tube in, and they're not doing anything. They're not moving or anything. So can they feel the tube? If they're light, yes. But in general, we want them deep enough they don't feel the tube. And then the blue dye is a very special dye. We call it the Duke Spine dye, but it really is something called indigo carmine. And indigo carmine is a vital dye made in primarily India and other countries. It's very special, and it stains the herniated disc. It stains the herniated disc that's degenerating blue. It's a blue stain. Shot? Okay. Shot? It's a blue stain. Shot? Perfect. Take that, take that. Okay. So I'm very happy. We're right next to the spinal cord, so we just have to be really careful. So indigo carmine stains the degenerated nucleus pulposus, which is the herniation basically, stains it blue. Shot? Now the tube is going in. How is he? Stable? I think that is probably as good as we can do, right? Maybe that's it. All right. So now we have a tube in the disc. Shot? Hold on. All right. Here's a wet one. Just give us a minute while we work. We've basically cold welded the dilator and the tube together by getting some herniated disc in between the two of them. Shot? Good. Luis, nice job. Luis is the man once again. All right. You guys can see what we've done here. We've done this for so many years. We feel really confident. There's a tube sticking out of this person's back like a porcupine. But that tube goes straight into the disc that's herniated and torn. That's causing all this patient's pain. It's a thoracic disc. This is number 1011. Next, we're going to do 910. That will be our last one. Okay, you can see we're inside the disc. That's the herniation we're looking at. And we're going to take these pieces out. Look at that thing. There's a piece of herniation. So this definitely was the painful disc. You know, when you look at his MRI, you can't really tell for sure. We had to pretty much use some deductive reasoning, testing. We got an x-ray right where his pain was. We used paper clips to figure it out. And then I looked at the MRI. It was originally read as normal. And I looked carefully at it and I realized it's not normal. It's just subtle. And like most thoracic herniations or even lumbar, subtle abnormalities are what cause pain. It's the subtleties. The devil's in the details, as they say. So I'm glad we figured it out. But this is a 10 out of 10 pain for this patient. 10 out of 10. Laser. Now, for those of you wondering what's the laser, this is a glass fiber. It's a fiber optic fiber. And all it does is transmit energy in the form of a wave called electromagnetic radiation from a laser generator, aka the laser, which is made in Israel from Luminous, best laser in the world. And it transmits that laser energy right here to the end of the fiber. where the herniation is. And look at all the scar tissue inside this disc. He's had this pain for years. No wonder. Look at all the scar tissue. This is literally a 30-year-old injury to the disc. You can see it. So we did the right thing in fixing this disc. I have no doubt about it. We got one more to fix after this. We'll be done. Everybody else gone?
Did he void? Can we check that, please? I didn't get a number on it.
All right. Yeah, he can go when he's ready. I'll see him tomorrow. Boy, we got the P Brigade. The P Brigade, right? Yeah, we've been doing a lot of surgery lately, which is good. Been helping a lot of people. And that's why we're here, to help people. So, great questions and participation from our audience.
Yes.
If you have questions, feel free to type them up. I'll do my best to answer them for you. But we are just about finished. These thoracic discs are not as big as the lumbar. They're smaller. So we don't need to spend quite as much time on them as we do with the lumbar. But we spend more time than we do with, well, the Duke plasma rhizotomy. By the way, great job everyone today. I want to thank you all. This scope is beautiful, huh, Luis?
Yeah.
The picture is just so crystal clear. It's great to have everyone here with us while we're operating. We will be back Thursday for more surgery.
We have a question.
Yep.
This comes from Bird819 on YouTube. Once
Hi,
more,
Bird.
they ask, "What is the best way to prevent having to need this surgery?"
Yeah, great question, Bird. So how do you prevent having to need the surgery? This surgery is just for people with a herniated disc, bulging disc, ruptured disc, degenerated disc, spondylosis, any kind of a disc injury that causes symptoms. So the way you avoid needing the surgery is to avoid having a disc injury. How do disc injuries occur? Trauma. 100% trauma. There is no other reason. Trauma, trauma, trauma. Most doctors don't know that. Most people don't know that. But the only way you get a disc injury is through some type of trauma. Okay? It could be a fall. It could be falling off a horse. Could be falling off a bike when you're a kid. I've even had somebody who got traumatized to their disc when they were being born from birth canal. We had that patient last week from Seattle. Okay? So he had no history of trauma. He was a basketball player. When I talked to him and his mom, there was no history of trauma, no car accidents, no slip and fall. But when he was born with the umbilical cord wrapped around his neck. And he, they had to pull hard. They had to do a C-section to save his life, and they had to pull on him. All right, we're just about done here. Look at all this scar tissue, all this white stuff, scar tissue from chronic inflammation, not normally found in the disc. This is 30 years old, folks. That's what you're seeing is a 30-year-old disc injury. The blue stuff is recent herniation, and the white stuff is scar tissue. We are done with this disc. I'm going to pull out a little more. We may even see the spinal cord right here, just on the side of the spinal cord. It's crazy, huh? Pretty cool. We actually developed this technique in the Duke Spine Institute. I did years ago, doing a thoracic transforaminal endoscopic disc. And look at the beauty here. No doctor in the world does this kind of surgery but us. It's so advanced, they really don't even know how to do it, to be quite honest. It's kind of hard for me to believe, but it is the truth. So the spinal cord is literally right here. Kind of want to see it as we come out. We're just to the side of it. So that's the foramen we're in right now. There's the facet joint right there. It's a little bit arthritic. The spinal cord is medial, so it's protected by the facet. We're done. We got one more disc to go. So you're not even seeing the spinal cord. That's how protected it is with this technique. We're literally coming from the outside of the foramen. And it's amazing to be able to do this safely. It is obviously in high price real estate, no doubt about it, right? We could have a lung collapse, we could have a vascular injury, if we get out of line, we could injure the spinal cord if I'm not careful enough. This is a little sticky. Huh? I think it's just some disc material. All right, any other questions?
Yes. This comes from, forgive me, am I pronouncing this incorrectly? Aldrinin on YouTube. Aldrinin.
Hey, welcome. First time hearing from you.
Yes.
Thanks for joining our stream.
They asked, would you do the same on L4, L5, and S1? And what is the recovery period? I have complications of stenosis and herniation on my L4, L5, and S1.
Yes, we can do L4, 5, S1. We do it all the time. Those are the easiest for us to do. You're watching the hardest for us to do, thoracic. Thoracic is literally the hardest, what you're seeing right now. If we can do thoracic, we could do the L4, 5, 5, 1 with our eyes closed. No problem. And it will take us 1 hour to do, and the recovery is 1 hour. You literally can go home in an hour after the surgery. All of our patients we've been operating today are all gone, except for this one. And that's because they're still in surgery. But, an hour or so after surgery, they'll be gone. So it's safe, very fast recovery. Okay, last one. Shot? And by the way, that last disc was so hard for me to do the discogram. Remember, I was struggling to push the dye in. The reason is that it was full of scar tissue, just as I suspected. And this one is going to be full of scar tissue too. All right, you guys see the hole right there?
Yes, we do.
That is a thoracic disc, Duke laser disc repair done through a 7mm incision. Incredible. Why do you think people come from all over the world here? Because other doctors don't know how to do this surgery. They're not capable. And people want to get fixed, and they want to be fixed safely. They want to be back to their normal life the next day if possible, which we can do. And they want to be fixed permanently. They don't want to have to keep coming back for pain management or painkillers, more surgeries on the same places. All right, last disc. This patient originally came to us over a year ago because he had gone somewhere else and they gave him an infection in his spine. And he didn't know what to do. He was in so much pain, he couldn't sit, he couldn't do anything. He was pulling his hair out. He went to a place in Virginia, which I won't name, and they did a microdiscectomy and they gave him a spine infection. And he found out about us, called me, and I said, come here, we'll clean your infection out endoscopically, we'll put antibiotics, it'll be outpatient. He came, and we did it. And he was so happy, obviously, with his results, that he came back to get more work done. Okay? Because nobody else in the world can do what we're doing. All right, just about done. Shot?
We have another question.
Woo. That disc is full of scar tissue. Yes.
This next question comes from Canes25, once more on YouTube.
Oh my gosh. It's amazing how much scar tissue. Yes, Kane25, please.
They asked, where the cord runs through the thoracic, is the space much tighter? From what I think I understand, the space where the cord sits is much tighter in the thoracic, and I was always told it's a dangerous area because there's less room for the cord. And this is why most people have no idea the magnitude of what you're doing in the thoracic.
You are 100% correct. And most people have no clue what I'm doing and the magnitude of it. Because no surgeon in their world wants to do this thoracic spine surgery because it's so normally they have to rip open the bones and the spine, and you have to do what's called a lateral extracavitary or a costotransversectomy or a transthoracic, where you're actually going through the chest, removing the ribs, moving the heart and lungs over. You have a thoracic surgeon there. You drop the lung, you keep the lung deflated. You have to take out the disc, put it in a cage, flip the patient over. I mean, the mortality rate is literally 25 to 30% in a good doctor, and there's only about 10 of them in the world. Oh, the best team. You need a team. Yeah. And so now we're doing it outpatient, and we're doing surgeries no other surgeon would even touch because it's normally the way they do it, it's too dangerous. But what we're doing, we've been doing it now for years, and we've not had any problems. We published our data. We had a 99% elimination of thoracic pain. 99% at 13 months post-op with 0 complications in our cohort. So we're revolutionizing the spine industry and the spine world. And we're not doing it for people. We're not doing it for companies. We're not doing it for the insurance companies. We're not doing it for the government. We're doing it for people suffering, patients that need it. That's why we do what we do. I'm not here to impress anyone but my patients. That's why we're here. Because my father taught me, when you're a doctor, you do what's best for the patients, not what's best for the hospitals, not what's best for your colleagues or peers, not what's best for the insurance companies, not what's best for the companies that make screws and rods. You do what's best for your patients. And I believed him and I trusted what he told me. And so that's why I do what I do, because this is what's best for the patients. There's no doubt about it. But I had to pioneer it because nobody else was doing it. Look at the scar tissue. It is massive. All of this scar tissue, all of it. There's a tiny bit of herniation right there, old, blue. I couldn't even get the dye in because it was just all caked with thick, thick scar tissue. Now the normal disc is soft. It's soft and fluffy, like the fur on a bunny. This is like rubber, really hard. I can feel it with my laser. Look at the laser. It's hitting it and it's doing almost nothing. That's because every single second, what's our hertz? What are we at? 20 hertz, 30 hertz, 40 hertz? 45 hertz. We're at 45 hertz, folks. That means every minute we're dumping 45 times a minute, we're dumping energy through the tip of that laser into the disc, and a lot of it. This is like the highest setting, right? We've got almost maximum energy, not quite, because we don't want to blow the fiber or the laser. So we're dumping as much energy as we can safely put through this laser into the disc using the most powerful medical laser there is, that we, commercially available, of course. And look at how little is done with each touch, each movement, each second. The reason for that is this disc is full of scar tissue, massive scar tissue. And it's probably why it wasn't as painful as the other one, because it's more stuck down. 5 minutes, we're done. All right, so here's more herniation, but the whole disc is destroyed from the inside. And if you look at this disc on the MRI, 99.9% of doctors would ignore it. They would say, look at that disc, there's nothing wrong. Mild degeneration, if anything. That's how our radiologist read it. But I knew there was something more to the story. So I went back and I said, are you sure? Can you see these degenerative changes here in the front? And he said, yes, you're right. I said, well, don't call it normal if it's not normal. That's the problem with radiologists. They want to call everything normal when it's not normal. Because the problem is if they call everything abnormal, then the doctors are going to start ordering more tests unnecessarily, usually. So they want to minimize what they call abnormal to what's really, really abnormal, right? I remember I had a conversation with one of the radiologists I got upset with one time. This was years ago. There was a herniation I knew was causing pain, and he read the MRI as normal. I called him, I said, why did you read this as normal? Don't you see the herniation? He said, yeah, I see the herniation. I said, then why'd you call it normal? He said, because if I called it herniated, then every surgeon in this county will want to operate on that disc and do surgery. And I said, so? I mean, you can't call it normal when it's not normal. You know, what the doctors and the patients decide to do, that's between them. It's not your job to lie and make this stuff up. Okay? Of course, I stopped using that radiologist because he still thought at the end he was right. He argues. These radiologists, some of them are crazy. You have a neurosurgeon, high trained, highly experienced, veteran neurosurgeon telling you, you know, and you're agreeing that there is a herniation, and yet you still want to call it normal? Really? Now, he does work for an insurance company, so I could see why he'd want to call it normal. So the insurance company doesn't have to pay for treatment. Oh, it happens all the time. Look at all that scar tissue. 2 minutes, we're done.
We have another question.
Sure.
This comes from Algernon once more on YouTube. And they ask, what is the average wait time for an appointment? I want to come for a consultation as I've had 3 ESIs and need surgery.
Yeah. Well, I have good news for you, my friend. First of all, if you like, we have a free consultation, and it's virtual. You do it by Zoom. And I will see you personally, review your MRI, talk to you. Just, Henry's going to put the link right now. You can just use the link. It's free for anybody. You don't even have to come here and treat. We just want to give you your diagnosis so you know what's wrong. And if you decide someday to get it fixed, well, you know where to come. The other option is just to come in and see us in clinic if you want to drive or fly here. Our door is always open, and we do free consults a lot. So even if you have no insurance, doesn't matter. I'll see you for free and do your consultation for free, okay? That's because we want to help people get answers. The reason I do that is, first of all, I have the time to do it, and I feel it's the right thing to do for people. Second of all, I feel like if I was those people suffering with pain every day and my life was ruined, I would really want somebody to help me. And right now, the other doctors aren't helping people. So that's why it's important to help others. All right, we're done. Getting to the gilding the lily stage, which I don't want to do. Okay, we're done.
Lights on, please. Thank you. Everything on.
Thank you, everybody. You guys did amazing. I appreciate you sticking it out. Huh?
It's a wrap.
It's a wrap. What kind of wrap? Chicken? Tuna? Right, my mind. I wouldn't mind a burrito wrap. Little carne asada. All right. How do you do? Stable?
Yeah.
Totally stable?
Great blood pressure.
No, not stable. Stable. No, Luis has got the stapler. I want to show you guys.
You gotta find your cell phone. That's what it is. Yeah.
I want to show you guys these incisions, right?
We have one more question.
Sure.
This comes from Jackie on Facebook.
Yep.
And they ask, can a disc that is full of scar tissue fully heal after the surgery?
Yes, it can. I mean, Jackie, first of all, so let me repeat the question for the benefit of everybody. Can a disc that's full of scar tissue fully heal after the surgery? So the definition of heal to me means that the disc will heal with collagen and seal the hole that's there. And it will be pain-free. In other words, no symptoms, no back pain, no arm pain, leg pain, rib pain. So no radiculopathy. But will the disc go back to looking like a normal disc, like when you were 15 years old? Absolutely not. Our surgeries, nobody's surgery can make your disc look normal, period. We don't do cosmetic spine surgery, right? Why? Because it's unnecessary to try to make spines look perfect. There's no surgery in the world that will make your spine look normal. What our goal is to take away pain in the back or neck or thoracic, leg or arm symptoms or rib symptoms, like pain wrapping around or down the leg or down the arm, weakness, numbness, tingling, okay? That is the goal, and to make it a permanent fix so that people don't come back. All right, let's look at the holes. There's your holes. They are 7 millimeters each, okay? And we just fixed 2 thoracic herniations, T9-10, T10-11, with only about 10 cc's of blood loss, 10 milliliters. I'll hold it. I'll hold it. You go. So the reason I'm putting pressure on the muscles is because the muscles, you know, the venous bleeding you see is bleeding from a vein, right? You have artery bleeding and vein bleeding. Artery bleeding is bad. You don't want artery bleeding. Artery bleeding comes out at a pressure of 120 millimeters of mercury. So your body can't stop that. It's just going to hemorrhage internally. Vein bleeding, on the other hand, comes out at 10 millimeters of mercury or 12 millimeters of mercury, 10 times less. Your body can stop that on its own. But just so that we don't get any blood in the muscles of the back, I put pressure, because once you get a blood clot in there, then it's going to cause pain. And the patient's going to have pain in their muscle for like months after surgery. And they're going to complain about it and be unhappy until it dissolves and goes away. So rather than deal with inflammation in the muscle, called myositis, from a clot from surgery, it's better to control the blood pressure, keep it down. Don't let it bleed by putting pressure if you have venous bleeding. All right, I hope you enjoyed the broadcast. Henry, let's wrap it up.
Copy that.
We'll see you all on Thursday for more surgery. Everybody, great job.